Okay, sir.
Mm.
Good evening, everyone. Today, my question of presentation is about neonatal resuscitation.
Mm.
First, we start with the algorithm.
Mm.
Initially, uh, we do the antenatal counseling, then team briefing, and then equipment check. Then, at the time of the delivery, we see whether the gestation is of term gestation and the baby neonate has good tone and has good breathing or crying efforts.
Very
If
good. Mm.
if all these are present, then we can give the neonate to the mother to keep the neonate warm and maintain the normal temperature, and then position the airway and clear the secretions if needed.
Very good.
And if
Mm.
above all these are absent, then we should clean the patient and may warm the
Mm.
patient, and then maintain the normal temperature. Then
Mm.
again clear the secretions if needed. Then, if neonate has apnea or if she has gasping, or if the heart rate is less than 100 per minute, um, if above the if apnea or gasping is present, then
Mm.
we should start with positive pressure ventilation,
Mm.
SpO2 monitoring, and then consider ECG monitoring.
Mm.
And if apnea or gasping is absent, if she has only labored breathing or persistent cyanosis,
Mm.
we should position the airway and then clear the airway, then
Mm.
monitor SpO2, and then supplementary oxygen is given
Mm.
as needed, and then consider CPAP measurement. If still further neonate has heart rate less than 100 per minute,
Mm.
we observe whether the chest movement is there, and then ventilator corrective steps should be done, and
Mm.
then we should intubate the patient with ET tube or LMA if needed.
Mm.
And if heart rate is not less than 100 per minute, if it is above 100 per minute, then we can use post resuscitation care and then do the tip briefing.
Very
If
good.
still heart rate is less than 60 per minute, even after ventilator corrective steps are done,
Mm. Mm.
then chest compression should be started with the
Mm.
two finger technique, two
Mm.
finger and encircling technique, and then positive pressure ventilation should be continued. Then
Mm.
100% O2 should be given. Um, SpO2 monitoring and ECG monitoring should be done, and then IV lens intravenous access should be done using umbilical venous catheter.
Mm.
Even if still the heart rate is less than 160 per minute,
Mm.
consider giving IV epinephrine at the dose of 0.01 mg per kg, 0.01 to 0.03 mg per kg. This IV epinephrine can be repeated at 3 to 5 minute interval. If
Mm.
still if heart rate is less than 60 per minute, even after epinephrine administration, consider in a therapeutic hypothermia,
Mm.
and then give the post resuscitative care. And then under the following headlines, initial umbilical cord management, it is recommended that the term infants who are receiving early cord clamping,
Mm.
compared with the term infants receiving early cord clamping, those with delayed cord clamping had increased hemoglobin concentration within the
Mm.
first 24 hours and increased ferritin concentration in first 3 to 6 months. It is reasonable to delay cord clamping for more than 30 seconds in preterm babies,
Mm.
because the delayed cord clamping reduces need for blood transfusions, and also it maintains the blood pressure support. Temperature management at birth and in the newborn infants. Immediately after delivery, babies should be kept skin to skin with the mother. In case of preterm babies, preterm and low birth weight babies who require resuscitation, warm adjuncts warm adjuncts like radiant heat warmer or blankets, exothermic mattress, and warm and humidified inspired gases can be given to maintain the temperature.
Mm.
If the when the babies are in out of hospital setting or in limited resource setup, it is reasonable to use clean food grade plastic bag as an alternative to skin contact.
Mm.
And coming to clearing the airway and then tactile stimulation,
Mm.
in babies who are breathing well or crying, routine oral nasal suctioning and tactile stimulation is not recommended.
Mm.
Avoiding the suctioning reduces the risk of induced bradycardia.
Mm.
In babies with ineffective respiratory efforts, tactile stimulation is beneficial and suctioning may be considered if positive pressure ventilation is required and the airway appears to be obstructed.
Mm.
Then in newborn infants born through meconium stained liquor, in case of non-vigorous newborn, that is baby with apnea or if has ineffective breathing efforts,
Mm.
delivered through meconium stained amniotic liquor, uh, tracheal suctioning is beneficial.
Mm.
Assessment of heart rate during neonatal resuscitation. During resuscitation of term and preterm newborns, the use of ECG for rapid and accurate measurement of newborns for heart rate is reasonable. Use of ECG does not replace the need for pulse oximetry to evaluate the oxygen saturation or need for supplemental oxygen. Then coming to ventilatory support after birth, during the initial breaths in the newborn infants who are either gasping or apneic, even in within 60 seconds after the birth, or who are bradycardic, that is heart rate less than 100, despite appropriate initial actions, positive pressure ventilation should be provided without any delay. The positive pressure ventilation should be given at the rate of 40 to 60 inflations per minute.
Mm.
In newborn infants who require positive pressure ventilation, it is reasonable to use the peak inflation pressures of up to 30 centimeters per 30 centimeters of water in
Water.
case of term, and 20 to 25 centimeters of water in case of preterm. Uh, in case of preterm infants, the positive pressure ventilation should be given with inspiratory time of 1 second or less. Then considering the CPAP, and for spontaneous CPAP is considered in case of spontaneously breathing preterm infants who
Mm.
require respiratory support after delivery.
Mm.
Then coming to oxygen administration,
Mm.
in term and late preterm newborns, initial use of 20%, 21% oxygen is reasonable.
Very
In
good.
case of preterm babies, oxygen support can be given at from 21 to 30%. In term and late preterm newborns who are receiving oxygen support, giving 100% oxygen is harmful.
Very good.
Then coming to chest compressions, if heart rate after birth remains less than 60 per minute, despite adequate ventilatory efforts for at least 30 seconds, chest compression should be immediately started.
Mm.
Uh, during the chest compressions, it is advisable to use higher concentration of oxygen. Then coming to compression to ventilation ratio, it is reasonable to deliver the compressions at the rate of 3 compressions with 1 ventilation. It is better to use 2-thumb encircling technique over the 2-finger technique,
Very good.
as it is associated with improved blood pressure, and then less provider fatigue.
Okay.
Then coming to intravenous access, for babies requiring vascular access at the time of delivery, umbilical venous catheterization is the recommended route.
Mm.
If the intravenous route is not feasible, intraosseous route is recommended.
Very good. Mm.
Then coming to medications used in neonatal resuscitation,
Mm.
if the heart rate has not increased up to more than 60 per minute, even after chest compressions, positive pressure ventilation, it is reasonable to administer IV epinephrine at the dose of 0.01 to 0.03 milligram per kilogram. If IV access is not available, epinephrine can be given via endotracheal route at the rate with the dose of 0.05 milligrams to 0.1 milligram per kg. Then further doses of epinephrine can be administered every 3 to 5 minutes, preferably IV if the heart rate remains less than 60 per minute.
Very good.
Coming to usage of volume expanders, when the blood loss is suspected in a newborn infant, who responds poorly to resuscitative efforts such as ventilation, chest compressions, or epinephrine, it is reasonable to administer volume expanders without any delay. The 0.9% normal saline is the fluid of choice. And then uncross-matched blood of O negative type is preferred when the blood loss is substantial. And the initial volume of 10 ml per kg over 5 to 10 minutes is recommended, and it may be repeated if there is an inadequate response. Then coming to the post-resuscitative care, in newborn infants who receive prolonged positive pressure ventilation or advanced resuscitation, they should be transferred to a neonatal intensive care unit. And then these newborns are more prone for hypoglycemia, so glucose level should be monitored as soon as possible. And then for the newborn infants who are unintentionally hypothermic after resuscitation, it may be reasonable to rewarm rewarm them either rapidly, that is rapidly with at the rate of more than 0.5 degrees Celsius per hour, or slowly, that is less than 0.5 degrees Celsius per hour. That's also post resuscitative.
Okay. Now you have done a wonderful job, excellent preparation. But I would like to add a few more points to this. You have more or less covered all the points. But
Yes,
first
sir.
and foremost, if this is a theory question appearing in your theory paper, you must first define what is neonatal resuscitation before you straight away go to the algorithm or flow chart. I think you
Okay, sir.
first define what is a neonatal resuscitation.
Okay, sir.
Can you define what is a neonatal resuscitation? The definition.
Definition.
It can be defined as the acts or the measures to be taken for
Okay, sir.
infants who are not able to transfer themselves from the intrauterine circulatory method to the extrauterine life. Okay, intrauterine, their lungs are not working. They are
Yes, sir.
dependent on the placenta for all the functions of their life to be alive. Whereas
Yes.
once they are born, they get a transition from the placental circulation to the lungs getting opened up and the regular circulation starts. So
Okay,
children
sir.
who are babies who are not able to go into a smooth transition like this, they are the ones who suffer from this part of problem. So they only require the
Yes, yes.
assistance or resuscitation from us. So our first and foremost duty is to identify, as you rightly put it up, which are the babies who require a resuscitation, who are the babies who don't require a resuscitation. So for
Yes, sir.
that, we are usually asked these three questions. Is the baby born prematurely or is it born at the time of full maturity, at full term? Second question is the baby immediately crying and breathing well after delivery, or is it having some difficulty in breathing? Third question is the baby having a good muscle tone by moving its, flexing its limbs and hands, whether it is having a normal muscle tone or a reduced muscle tone.
Yes.
Earlier algorithm or this the so-called guidelines, they were including another point also, whether the mother had any evidence of infection like amniotic infection or the vaginal tract infection, or the amniotic fluid, was it clear or meconium stained, was also included in the earlier 2010 algorithms, but that has been
Okay,
now
sir.
removed. So another point you have to add to this answer is what are all the changes or the advancements or the alterations done in the guidelines periodically. So there was one
Okay, sir.
guideline in 2010, then another one 2015, and the recent latest one is 2021.
20.
So
Yes.
20 and 21 European
Okay,
guidelines
sir.
also has come.
Okay, sir.
So
Okay, sir.
you have some subtle changes going on in all these things. That also has to be brought out. Okay,
Okay, sir.
and
Yes, sir.
all the other points you have beautifully mentioned. And finally, you must also mention about when to stop or they make a decision to not to continue with the resuscitation, which are all the babies who cannot be salvaged, or
Yes, sir.
whether you should not attempt at all. it is withholding the resuscitation or discontinuing the resuscitation. That is a very important step that has to be, because you cannot be endlessly going on doing the resuscitation.
Yes, sir.
And for this point, you should have an anticipated as soon as the first step you should go, where you ask whether the baby is a full-term baby or whether it is crying immediately or not, whether the muscle tone is there. Before that, you must be able to anticipate that the child born may have a need for neonatal resuscitation. So there are
Okay, sir.
factors with which we can assess whether the child which is going to be delivered by the mother, will it require a new resuscitation? For example, a prolonged labor or a mother who has been administered opioid 4 hours prior to delivery. You naturally expect the baby to have the effect of opioid with a respiratory depression.
Yes.
Or some infection. Like that, there are parent, or the child is intrauterine growth retardation child. Is it a case of polyhydramnios or oligohydramnios? All these things in the mother and the fetus, they all may indicate that the child, when it is born, may require a resuscitation. So anticipating the resuscitation is very important from these factors. And from then on, you go for all these steps in the resuscitation. And then you finally decide whether to continue the resuscitation or not to resuscitate. For example, if the baby is born as an anencephalic baby and it is not breathing well, but there is a heartbeat, there is no point in resuscitating the baby at all. You will be landing up with only a child which will be completely neurologically defunct, and it will be a burden on the parents. So withholding the resuscitation also is an important criteria which you have to decide about. Okay.
Okay.
So
Okay, sir.
very good. You have done a wonderful job. I will just show some Kamachi. Can I share?
Yes, please, sir. Yes, please, sir.
So are able to see?
Yes, sir.
Okay. So neonatal resuscitation can be, these are the questions that you have to first ask. What is neonatal resuscitation? Then you have to assess the baby at the time of birth. Then identify the babies which require resuscitation. What are all the initial steps in the resuscitation? Then the resuscitation consists of pulmonary resuscitation and vascular resuscitation. Another important difference you will find between a regular adult or other resuscitation and a neonatal resuscitation is we always start with the pulmonary resuscitation. Unlike an adult, nowadays we talk of colds, compression only life support, where we start with the cardiac compression. But in the neonatal resuscitation, please remember, if you saturate the respiratory function, heart will automatically pick up. So you don't go for cardiac compression first. You always try to saturate the pulmonary deficiency, then heart will automatically pick up. If after correcting the pulmonary deficiency, if the heart is not picking up, then only you have to go for resuscitation of the heart. So that is a very important difference between an adult resuscitation and a neonatal resuscitation. And when to terminate the resuscitation. These are all the headings under which we have to write the answer for that. So the neonatal resuscitation is a series of actions used to improve the newborn babies who have difficulty in making the physiological transmission from intrauterine to extrauterine life. So those babies who are not able to adapt to the extrauterine life, they are the ones who require that. So quickly you have to assess the newborn. It's all time restricted activities. So you have to complete everything within 1 minute's time. So very, very important. You can't be wasting time on assessment and then taking your next step. So if the term baby, that you will know even before the baby is delivered by the asking the physician whether the mother is delivering a term or not. This is very easy to find out. And after birth, these are the two things we have to find out, whether the child is crying immediately or having a good muscle tone. If all the three questions are yes, it doesn't require any resuscitation. So you can just take care of it as a normal baby. Whereas if the answer is no for any of that, infant should be receive one or more of the following actions. Initially, that is, you can also write this answer as ABC survey, airway, breathing, circulation. And then initial steps of stabilization, ventilation, chest compression, administration of volume epinephrine and volume expansion. These are the 4 important things that we are finally going to do. Then coming to the next thing, this is the golden minute, 60 seconds of initial steps, re-evaluating and beginning ventilation if required is the very important time we have to remember. Decision to progress beyond initial steps is determined by simultaneous assessment of respiration, heart rate. These are the 2 things which we take care of. Once positive pressure ventilation or supplementary oxygen administration has been started, simultaneously evaluate the heart rate, respiration, and state of oxygenation. The most sensitive indicator of a successful response is return of heart rate to normal. This is the best indicator to show that your resuscitation is going in the right direction. So mostly the children will have a bradycardia. If the heart rate goes up to beyond 120, that means you are doing a wonderful job in resuscitating the baby. Once it is remaining lower than 100, that means your resuscitation is lacking somewhere. And resuscitation equipments, what you need are the resuscitation bed or overhead warmer, towel, stethoscope, pulse oximeter, and airway management suction device, suction catheter, bulb syringe, laryngoscope. You must have the lowest, smallest size plates, 0 and 00, and ET tube 2.5, 3.5, ETCO2 detector, and nowadays they recommend LMA. LMA was introduced as an alternate airway equipment only in 2015. 2010 it was not there. So such small changes have been done. And then breathing support, either a face mask, positive pressure device, oxygen gas feeding tube, circulation support. You have to have umbilical vein catheter and other IV cannulae, and drugs and fluids, adrenaline and normal saline blood. These are all the things that we require. So these all should be checked and kept ready in case you anticipate that the baby born may require a resuscitation. So all the neonatal resuscitation equipment should be kept ready before you deliver a child where you may anticipate resuscitation requirement. So these are all the pictures of those equipments which are required: radiant warmer, oxygen source, anesthesia. You have a near resuscitator. The equipment name is resuscitator. It has got an automatic airway pressure venting valve so that you don't blow out the lungs and cause damage. And it has got a pop-off valve of more than 250 ml, suction infant feeding tube, low pressure suction bulb, stethoscope, laryngoscope, ET tubes. Of course, this is a wrong picture with a cuff tube. It's there. You don't use a cuff tube. You use only a plain. And transport incubator and ETCO2 monitor, which can be attached directly to the tube and found out. Now, this is the 2010 American Heart Association algorithm for newborn. So these are the 3 questions that we asked, whether it's a term gestation, and you can see it is a time bound. So within 30 seconds, you have to do all these things and take a decision. So if the heart rate is below 100, gasping or apneic, these are the 2 criteria. First start PPV. Don't go for any cardiac compression. So positive pressure ventilation, SpO2 monitoring. If the heart rate is still 100 or below, then see whether you are correctly ventilating. That is the second step. So first step to initiate ventilation. Second step is to check and correct the ventilation. And if the heart rate is continuing to go down below 60, then consider intubation and proper ventilation. So 3 steps are given only for ventilation. First step is for proper positive pressure ventilation without intubation. Second one is correcting, clearing the secretions and other things. Third one is going for advanced ventilatory management. So by doing these three steps, you expect the heart rate to come back to normal. If still the heart rate is not coming back to normal and it is still low, then only you go for IV epinephrine and correct hypovolemia, pneumothorax and all those things. And then once the heart rate picks up, you have to take care of the post-resuscitation also. And the SpO2 will not be 100% in a newborn. You have to remember that. At 1 minute after birth, it will be 60 to 65. At 2 minutes, it will be 65 to 70. Only at the 10th minute it will come to 85 to 90. So early low SpO2 you need not worry about. So after about 3 minutes or 4 minutes, if it is still less than 50, then you have to worry. Otherwise, normally it takes a little time, up to 10 minutes to become normal. That is a very important knowledge that you should have. Then in the 2015 update, what they did was, you can see there is a small change here. They check the chest movement, ET and laryngeal mask. So here it was an intubation, whereas in 2015 they said laryngeal mask can be introduced if needed for improving the ventilation. That is the only change. And only go for intubation if it is not already done when the heart rate is below 60. Okay, otherwise all the other things are all the same. So the only change that has been incorporated in 2015 update is the introduction of laryngeal mask airway to the algorithm. Then in the newborns who do not require resuscitation, delaying the cord clamping, all those points you said will reduce the anemia. So more blood will be given to the baby. And no type of routine suctioning. Previously, they were advocating in 2010 and all, you must routinely suction the nose, suction the mouth, and then take out all the amniotic fluid or whatever the child is swallowing. That is not at all recommended now. And unless only meconium stained, you have to take care of that. And heart rate should be monitored by ECG. This is the next improvement or modification that earlier it was only by pulse oximeter or by auscultation that we were monitoring the heart rate. Nowadays they say that in the 2021 they say as early as possible put an ECG monitor to monitor the heart rate. Positive pressure ventilation should be started in newborns who are gasping and apneic with a heart rate below 100 per minute within 60 seconds of life. That time interval, that is why it is called the golden minute. So do not delay. And this is the latest 2021 update you can see here. So here what you do is you have to do an antenatal assessment and check supplies and keep all the allocated. This was not there earlier. So nowadays we know that we have to anticipate in some babies a need for neonatal resuscitation. So if you need that, you keep yourself equipped, and always one person who is trained in neonatal resuscitation should be available in all deliveries. And delivery time, again the same 3 questions, and then consider delayed cord clamping. This is also introduced in 2021. And of course, we are going to place the baby under a heat source and positioning the head and drying the baby and repositioning the head. These are all small modifications. And then all the other steps are going to be the same until you go on to use the drugs and other things. And here, once the baby doesn't require any resuscitation, skin to skin contact with the mother should be established. This was not there in the earlier ones. Now it has been introduced. And here again, the SpO2, they start from the 3rd minute. You don't worry about the first 2 minutes because it is around to be 60, 65. You go for the 3rd minute only and then try to late preterm infants may manage as a term infant if breathing and muscle tones are adequate. So this is how you, even if they are born slightly premature, that is say about 36 or 38 weeks, but they are breathing and their muscle tone is normal, treat them like a normal full-term infant. There is no need for any special attention. Now, anticipation of resuscitation is very important. Every birth should be attended by one person who is trained. Additional personnel needed if they think it may be a complicated resuscitation. Equipment checklist and role should be briefed, and everybody should be available. Care of the well-born, early skin-to-skin contact is very important. So this is how the baby is made to lie on the mother's chest with the contact. So the baby also feels reassured and mother is also happy. And routine suctioning should be avoided. Of whether oral or nasal is not recommended. This was there in the earlier 2010 recommendation. Now this is they have found out that it causes bradycardia in the baby. So routine suctioning is not needed if the baby is crying vigorously and breathing well. So this should be avoided. Okay. And delaying cord clamping for more than 30 seconds is reasonable for term and infants who do not require resuscitation. Delaying clamping increases hematocrit and iron levels without increasing the rates for phototherapy for hyperbilirubinemia and neonatal intensive care and mortality. So slightly delaying for 30 seconds the cord clamping helps. Then milking the clamp should not be done. That is another thing that they say. Cord milking should be avoided. So previously, all the senior nurses, they used to squeeze the ET tube and then try to clamp it, thinking that they are pushing more blood. That is not recommended now. And then initial resuscitative actions, preterm and term newborns without good muscle tone or without breathing and crying should be brought to the radiant warmer for resuscitation. So try to do it under the warm lights. Don't do it on the just a simple trolley or something like that. And newborn temperature should be maintained between 36.5 and 37.5. And morbidity increases with hypothermia, especially in preterm and low birth weight patients. And according to the recommendation, suction is only necessary if the airway appears obstructed by fluid. Otherwise, no regular suctioning. For non-vigorous newborns and meconium stained fluid, endotracheal suctioning is indicated only if obstruction limits positive pressure ventilation. So if the baby has meconium aspiration, then you can put an endotracheal tube and suction it. Tactile stimulation is reasonable. So this is how you do the tactile stimulation. Earlier days, all of you would have seen they used to hold the baby upside down and slap on the back and the buttock. That is all not recommended now. You have to just squeeze the legs and then rub the feet. That is all the tactile stimulation that you have to do. And ECG should be applied as early as possible rather than depending on the pulse oximetry. So you can put the ECG electrodes like this to monitor the heart rate. Nowadays, we have got wireless ECG electrodes. So this is a picture of where you can just put the electrode and it picks up. Nowadays, we are going in for what is called contactless monitoring, especially after the COVID. It has become a very important topic to do what is called contactless monitoring. I don't know how many of you have read about it. I learned it only today. And ventilation and oxygen support. So within the first 6 minutes, 60 seconds, that is first minute, you should try to do all that and get the heart rate above 100 and positive pressure 40 to 60 inflations with a maximum pressure of 30 centimeters of water. And in fact, the resuscitator or the ambu bag you use for the babies, usually it has a pressure relief valve at 25 centimeters so that you don't damage the lungs. And you can use PEEP up to 5 centimeters of water. So this is how you do the resuscitation. In preterm infants younger than 30 weeks of gestation, positive pressure instead of intubation can reduce the bronchopulmonary problems. And newborns at 35 weeks of gestation or later, you start with only 21% oxygen. So born before 35 weeks, oxygen concentration above 50% are no more effective than lower concentration. So because of the fear of eye problem that can happen, the so-called, what is that?
Retinopathy of premature.
Prematurity. So in premature baby, don't use the 100% higher concentration. 21 to 30% should be sufficient. And you can see the saturation is only 88%, but that is acceptable. And then coming to the chest compression, if the heart rate remains below 60, despite 30 seconds of adequate positive pressure ventilation. So they always give first priority to proper ventilation. And if in spite of your adequate ventilation, if the heartbeat is still low, chest compression should be initiated by two-thumb technique at the rate of 3:1 compression to ventilation ratio. So these are the two older techniques which we used to do. Encircling the chest and then using the thumb for resuscitation, or supporting the back with the one hand and then using two fingers from above, the index and the mid finger, for pressing the lower part of the sternum. These were the two things. This is not recommended anymore. Now they recommend only this technique, encircling technique. And if you are a single person who has to do both the ventilation and resuscitation of the, compression of the heart, then this is recommended. You can fold the mask to the face and continue to ambue the baby. At the same time, use your fingers for compressing the heart. So this is a single person resuscitation. And before chest compression, you should make sure that the ventilation is optimized properly. This is a newer method of, this is another technique of this new thumb, two thumb method. Here you are keeping the thumb side by side, whereas here you are keeping it one over another. Now there is a latest technique, newer technique called the newborn chest compression technique, where you keep both the thumbs side by side with your fist closed, and the thumb should be at 90 degrees, and you start compressing. This is the newest and latest new technique. So developed by Mereka et al. The new two thumb technique consists in directing two thumbs at the angle of 90 degrees to the chest while closing the fingers of both hands in a fist. So the hand is, these fingers are exactly at 90 degrees to the lower part, lower end of the sternum, and you just give compression like this on a flat board with support on the baby. Now, European guidelines 2021, the summary is management of umbilical cord, about clamping, what we had told earlier. Infants born through meconium stained liquor, non-vigorous infants only, you recommend aspiration. Otherwise, if the baby is nicely crying and breathing in spite of meconium aspiration or stained liquor, you don't have to do anything. You just have to observe the baby. And use a laryngeal mask instead of intubation is also, if ventilation with face mask is unsuccessful, or if you are not able to intubate also, you can use a laryngeal mask as an alternative means of establishing airway. But the infant should be more than 34 weeks. That is the only caution that they say, gestation, or it should be about 2 kgs weight. Although some devices have been used in infants up to 1.5 kg. And the inflation pressure maximum should be 25 to 30, and especially in preterm babies. And air oxygen should be the not 100% oxygen is not recommended, 21 to 30%. And chest compressions are required, and inspired oxygen can be there for 100%, can be there for a very short period, not for long periods. And vascular access should be, usually you choose the umbilical vein over other areas. Adrenaline, glucose, and the observation of prognosis are very important. And so this is the vascular access. Normally we do like a peripheral vascular access in the wrist. This is the scalp vein where you can cannulate if you are, and these are the umbilical artery, umbilical vein cannulation. There are two arteries and the vein. So this is how the umbilical vein is cannulated. And this is the intraosseous method of infusion. You have special needles for that, which is a 15 mm needle or 25 mm needle, and you can use this. So these are all the equipment needed for intraosseous. So instead of trying to force with your fingers, you have got a sort of gun which you can just press and press this button. It will go through the bone and establish the airway. And you have got all the IV tubings which can be connected to that. Or very rarely you can go for a central vein access also. So it can be either a tunneled or an untunneled if long-term resuscitation or supplementations are needed. Then factors to indicate the need for neonatal resuscitation, you can classify them into antepartum and intrapartum. Antepartum, fetal causes are either an IUGR or a premature baby, multiple pregnancies, or serious congenital anomalies are detected by antenatal checkup, oligo or polyhydramnios. These are all the fetal causes where you anticipate that the baby may require a resuscitation. Coming to the maternal causes, infection, gestation diabetes, pregnancy-induced hypertension, preeclampsia, obesity, short stature, preterm lack of antenatal steroids, all these things may indicate a need for neonatal resuscitation. Or intrapartum factors, evidence of fetal compromise, where the non-assuring cardiotocograph, where the decelerations are very frequent, or a meconium-stained amniotic fluid, delivery of a breech or a forceps or vacuum delivery, significant bleeding, C-section before 39 weeks, emergency C-section, general anesthesia. All these things can result in the need for a neonatal resuscitation. So this is the picture to show an IUGR. This is the same baby born at the same time. This one is a retarded growth. This one is a normal growth. And this is how in the twins, one baby may be normal, other may be retarded. And this is the baby with a normal, what is that? All the caseous vernicose or something like that. The normal looking baby. This is the meconium stained baby with a darker color smearing all over the body. And the top messages are delaying the cord, especially in normal babies. Effective thermal care is very important by dry wrapping and stimulation. Assess breathing and heart rate. Faster heart rate indicates adequate oxygenation. So this is a very important point. Simple steps to support airway and breathing will manage most of the problems. There is no need for any heroic intubation or anything. Chest compressions only once effective ventilation is established. This is a point repeatedly you have to remember. You have to start chest compression only after establishing effective ventilation. And if still the heart rate remains low only, you have to go for chest compression. Then classification according to initial assessment. Earlier they were using UPGAR score for 1 minute UPGAR, 5 minutes UPGAR, 10-minute UPGAR were used for assessing the infant at birth at 5 minutes and 10 minutes to decide whether there will be permanent neurological damage or not. All that is not now included in the algorithm at all. But the two components of UPGAR, the respiratory and heart rate are taken into, and the tone, they are taken into account. So if an initial assessment of the tone, breathing, heart rate help determine the need for resuscitation. So if there is a good breathing, good heart rate, good tone, it's a normal baby, just leave it off. Then if you are just giving the respiratory support and then there is a good tone, vigorous breathing, then that is a satisfactory transition from the fetal life to the extrauterine life. When there is a reduced tone, when there is inadequate breathing and heart rate low, that means the patient is not got into the transition from uterine to extrauterine life. That is an incomplete transition. And if the patient is very floppy or pale and breathing is not there or it is apneic and heart rate is less than 60 or undetectable, it is a very, very poor transition. So this is the baby which requires the maximum support. This will be easily salvageable by good ventilation. So this is how you assess the transition. And if there is an airway obstruction, you have to just normally correctly position the child. That itself is important, enough to maintain the air entry. So it should be neither too flexed nor extended. It should be in the neutral position. And the lifting the jaw sometimes is more than enough than doing anything else. And oropharyngeal airway may be sometimes needed, or a nasopharyngeal airway also can be considered. So how to decide the length of the oropharyngeal airway is from the angle of the mouth to the angle of the mandible. Whereas for nasopharyngeal, it is from the nares to the tragus. So these are the two small differences between these two methods of assessing the airway. And there are machines available nowadays which take away the fatigue of your hand trying to oxygenate the patient. Neopuff positive pressure device is there. So you have a patient circuit, have all the gadgets, so it can deliver oxygen and the gas mixture, air mixture. This is the delivery outlet to the patient, and there are airway pressure gauge to safeguard that you don't overinflate and cause too much of pressure. So this will automatically show the pressure and release the pressure also if there is a higher pressure. So the maximum in gas inlet outlet, maximum pressure release knob, positive pressure knob, all these things are there. Can you just identify what is this equipment? Now that it is attached to the endotracheal tube, can anyone guess what it is used for? I told you earlier how to remove meconium. This is called a meconium aspirator. Okay, so you can attach
Without
this.
applying pressure.
Yeah, you can just
Just
suction
pull up.
it and then remove it. So this is the meconium aspirator which can be used after intubating the baby. Then what are all the drugs you have to use for active resuscitation? When the heart rate is not picking up, you go for adrenaline. All the dosage was described nicely by Sanjeev Raju, 10 to 30 micrograms. So it is better to say in micrograms rather in milligrams. Okay, so that because it's a very small dose. And intratracheally also, if the patient is intubated, you can give. And then you have to always watch for glucose levels in the during resuscitation. So they should not be hypoglycemic. So you can use 10% glucose, and rarely you can use sodium bicarbonate if it is a prolonged resuscitation, not in short resuscitations. You can give 1 to 2 millimole per kg. And in situations of persistent apnea, and there is a history of administration of opioids, you can give naloxone. So if there is a history of mother receiving opioids 4 hours before delivery, you can give 200 micrograms of naloxone intramuscular, okay, not intravenous. And volume replacement is the last thing in the drug resuscitation, 10 ml per kg or O negative blood. And post resuscitation care, you have to take care of all the assess the neurological recovery is very, very important. So that and also post resuscitation glucose level monitoring is very important. Temperature care should be done properly. And you can use therapeutic hypothermia depending upon but there should be evidence to justify the treatment. It's very, very important. And the heart blood gases and neurological examination have to be done, and the parent should be informed about it. So when monitoring and treatment consider inappropriate application should be avoided without concern of the diagnosis of hypoxic ischemic encephalopathy. If this is suspected, after proper documentation and information to the parents, you can try therapeutic hypothermia. And then prognosis, ensure clinical records allow accurate retrospective time-based evaluation. Very, very important of the clinical state of the infant, especially nowadays, you know, many babies are very precious babies. And mothers go for infertility treatment and come for delivery at a as an elderly preemie, even at the age of 38, 40. And the baby is very precious. So in such events, it's very, very important that we record all the resuscitative steps and the progress of that in a very proper way, and communicate with the patient. Whenever there is any intervention is needed or anticipated, you must tell the parents what you are going to do and what do you expect out of that, what should be the result of that. Discuss the options and the potential need and magnitude of resuscitation before delivery and after delivery. Record carefully all the discussions and decisions in the mother's notes. When to discontinue resuscitation, failure to achieve return of spontaneous circulation in newborn infants after 10 to 20 minutes of intensive resuscitation is associated with high risk of mortality and high risk of severe neurodevelopmental impairment. So this is a very important point. You may resuscitate a baby after even 1 hour, but if the baby develops a neurological issue, encephalopathy, it will be a lifelong burden for the parents. They will have to support the child with all the deformities, and milestones will be delayed. So you have to take a proper decision. There is no evidence that any specific duration of resuscitation universally predicts mortality. This is the only dilemma where will be put into. We don't know when to stop. Severe neurodevelopmental impairment may happen. So this is a very tricky situation we have to hold. When will you withhold resuscitation? This is the earlier one was discontinuing after starting the resuscitation. Whereas when will you not do the resuscitation at all? That is in situation where there is extremely high predicted mortality or severe morbidity in surviving infants. As I told you earlier, anencephaly child born with a beating heart and with some good respiration. Apneic spells. You don't do a very vigorous resuscitation. So withholding resuscitation may be reasonable, particularly when there has been opportunity for prior discussion. So if you know by ultrasound there is an anencephaly or a very severe congenital malformation, then extreme prematurity or bilateral renal agenesis, which are all can be diagnosed antenatally. So withholding resuscitation or discontinuing the life-sustaining treatment following resuscitation may be ethically accepted. So it can be, it is not unethical, you don't do that. And clinicians should not be hesitant to withdraw treatment when it would not be in the best interest of the infant. This is a very, very important statement. So you should not continue the resuscitation if it is going to harm the baby lifelong. So successful resuscitation depends on this ability. So you are like an octopus. Time is very, very short. So you have to keep a watch on the time. You have to take care of the trachea, stabilize the head, monitor the heart rate, provide suction if necessary, and then bag the baby, check the tube placement, provide oxygen, tape the tube. So already all of us know that anesthetists are multifaceted or multitasking people. So we should bring our best by doing all these things to have a successful resuscitation. Okay.
Okay.
That's all. Thank you.
Thank you, sir. Thank you for a very wonderful, extensive coverage of neonatal resuscitation, sir. And I hope it will be a eye-opener for all our young students.
Okay.
In the coming days, the challenges to be faced by our young team will be really, really very much demanding in the emerging scenario of patients' expectation and advanced medical sciences. You have rightly pointed out the newer developments in the equipment gadgets available and the importance of documentation also, sir. Thank you very much, sir. Any doubts from the students? If no doubts, sir, can we decide about next week's case, sir?
I will decide that tomorrow.
Okay, sir. Okay. Yes, sir.
We could do something on exit procedure, sir. Now that I was listening to this resuscitation completely.
Okay.
I think they can have one person can probably talk on anesthesia for exit procedures.
Yeah, you are the authority on that. I think you are the only one who has done that.
Yes, sir, somebody can.
That can be a topic for discussion, and
one short topic, sir. One short.
You will be in charge of that fully.
Okay, sir. Okay, sir.
Yes, sir. Thank you, madam. Thank you.
Thank
So
you.
next week, this is repeatedly asked theory questions. So we can have theory question presentation of exit procedure.
Okay, right.
Okay. Thank you, sir. Thank you, madam. Thank you, dear students. With all your permission, can I sign off this meeting, sir?
Thank you. Thank you.
Okay.
So thank you very much, sir.
Thank you. Thank you, Rohit.
Thank you.